Morning and Assalamu alaikum. My name is Rahela Zaman. Today I'm presenting from my PhD thesis. The title is Insulin-Loaded Inorganic Particles and Managing Hyperglycemia. In today's clinical setting, what we have for the treatment of hyperglycemia or diabetics is very much effective. The treatment is all based on insulin replacement therapy. Although it's very effective, it's very low in patient compliance because the whole treatment regime depends on injectable formulations of insulin. The concept of our research was very simple. We wanted to take out this uneasiness from the treatment regime and replace it with an equal formulation which is effective but can be used very easily through oral route. Now, preparing an oral insulin formulation is very tricky. The reason is insulin itself is, as we all know, it's a protein molecule. We cannot simply eat or drink it. It will just degrade in our stomach. So in order for insulin oral formulation, first we need a very effective drug delivery system or a cargo. And that cargo has to meet a few criteria. First of all, it needs to bind or hold insulin molecule firmly. It needs to transport it through the GIT route. That means the drug delivery system itself needs to be very effective enough those degradations from pH or enzyme. The nanoinsulin should then transport through the intestinal wall to systemic circulation. And while in systemic circulation, there should be a mechanism to release the insulin or at least make it available to it for its activity. So it's like one single system has to address all these problems. And but we are here fortunate here because there are reporting of several formulations that can do this job. And in our research also, we found few formulations which we are going to discuss here. Most of the reportings for oral insulin formulations are preclinical level, and most of these reportings using drug delivery systems which are polymer based. That means using PLGA or chitin based molecules. Those showed limited success only. For our lab, we are specialized in inorganic salt-based nanoparticle systems, drug delivery system, which is relatively new in drug delivery system field. For inorganic, what we call inorganic salt particles are actually group 2 metal salt particles. There are few benefits for them. For example, the salt particles prepared of calcium, barium, or strontium salts. It's very easy to prepare it in lab. It doesn't need any harsh pH or elevated temperature treatment. So the preparation is also friendly for particle like conjugation of particle like insulin or any protein molecules. It's not going to degrade or lose activity because of the harsh treatment. And all these particles have a positive and negative ends. So it binds to a range of molecules, including the proteins. However, the biggest challenge was these particles has never been tried for oral delivery and never been tried for oral protein delivery. So we didn't know whether it can do this job or not. For this reason, actually, I had to go for a very vigorous screening of 20 plus formulations, and I was fortunate enough that there were more than one formulation that showed effective. For the limitation of time, I'm going to discuss barium salt-based nanoinsulin formulation here only. This is my hypothesis. This is what I was just discussing that now, the challenges for oral drug delivery system, protein drug delivery system. So I'm not going to repeat it, just to showcase. For barium salt particles, first it was characterized using FTIR method. The presence of sulfate group in the solution confirms the presence of particle formation here. The particle formation was further confirmed with FESEM method. Here the FESEM micrograph shows formation of clustered particles, oval shape, irregular, very much irregular, size between 30 to 200, presence of hollow structure in between for some particles. What's interesting, when insulin was added, the particle shape started changing from oval to elongated baseball shape, and the surface area looks like much more rougher, and the hollow structure almost got vanished. All this confirmed our insulin binding with the particle. After in vitro screening, characterization, and insulin binding study, this new nanoinsulin formulation was taken for animal study. For my animal study, I use Wistar Kyoto rat. These Wistar Kyoto rats were induced induced to drive diabetic using STZ, streptozotocin, 65 milligram per kg. And the diabetics was confirmed when the blood glucose level showed 13 millimole per liter above for a couple of days consistently. For animal study, I actually use insulin aspart, the commercial short-acting insulin analog, instead of the lab-grade insulin. The reason is I wanted to confirm this activity, onset, and duration with the formulation available in March. So first two control groups was given subcutaneously insulin aspart, and the onset of activity started less than half an hour. The highest activity was worked between 1 to 2 hours, and by 3 to 4 hours, activity started perishing. Now, this result is actually same with insulin aspart while given to human. And these are the data from oral nanoinsulin formulation. For oral treatment, I actually have two types of treatment strategies. One is barium sulfate loaded insulin given by oral gouging. Another one is barium sulfate loaded insulin given by oral gouging coupled with bicarbonate. The reason bicarbonate here is not part of the oral nanoinsulin formulation. It was given to elevate the stomach pH. I wanted to see if the elevation of stomach pH somehow affects the results on. For oral administration, I started getting a consistent result in a high dose, 100 unit per kg of insulin. The effect started, the blood glucose level started going down at 1 hour. The maximum decrease of blood glucose level was 2 to 3 hours, and after 4 to 5 hours, the effect started wearing out. The duration, onset, and duration of insulin, effect seems like almost same like the subcutaneous formulation here, and both of the strategies, only barium sulfate insulin and bicarbonate coupled barium sulfate insulin, both of them showed similar onset and duration, but the intensity of activity while coupled with bicarbonate seems like higher than only nanoinsulin formulation. So this is the summary of my in vivo findings. What's surprising is although in higher doses, the oral nanoinsulin effect was surprisingly similar to subcutaneous insulin aspart formulations. That means the effect started by 1 hour, and maximum effect was 2 to 3 hours. So when it started depleting, 4 to 5 hours. And bicarbonate generated elevated stomach pH level, improved the barium sulfate nanoinsulin formulation activity. This finding was published in Journal of Pharmaceutics last year, and this is the overall outcome of the project here, including the symposium and publications. So thank you very much. That's all for me.